Anyway, thank you for inviting me and thank you for attending this lecture. We're going to talk about shortness of breath or breathlessness, and let's see if I can figure out how to do this. There we go. So the topic is scleroderma lung disease, and I've divided this into three portions. The first is, what is it? What is scleroderma lung disease? Next, how is it diagnosed? And finally, we're going to touch on how it might be treated. So those are the three areas, and we're going to start with medical school. We're going to take you through anatomy, a little bit of physiology, cardiology, pulmonology, and so at the end of the talk, no exam, but I think hopefully you'll know more about how we breathe and why you might be short of breath related to your scleroderma. So there are many different causes of shortness of breath, and the medical term for this is dyspnea. So I may use dyspnea sometimes. How many of you have access to your medical records, electronic medical records? So if you look in there, sometimes you may see an abbreviation, SOB. Now that doesn't mean that your doctor doesn't think very highly of you. That's an abbreviation that stands for shortness of breath. So SOB, dyspnea, breathlessness can be used interchangeably. So this slide lists some of the causes of dyspnea in patients with scleroderma, and you can see it may be due to pulmonary fibrosis, sometimes referred to as interstitial lung disease. It could be due to pulmonary arterial hypertension. It can be related to heart disease from scleroderma or unrelated to scleroderma. It can be related to gastroesophageal reflux. It can even be related to the mechanics of breathing, and I'll mention more about that in a moment. It could be related to your blood, either not enough blood from anemia or forming blood clots that go to the lung. And sometimes it may be due to conditions of the lung that are not directly related to scleroderma per se, such as chronic obstructive pulmonary disease, emphysema, or bronchitis that may have occurred as a result of past smoking. So in medical school and during your residency in internal medicine, invariably the attending doctor is going to turn to the student or the intern and say, what is Occam's razor? And Occam was I think he was a Franciscan monk in the 15th century, 14th and 15th century. And he was also interested in logic, and one of his famous quotes was that plurality must not be posited without necessity, or this is sometimes known as the law of parsimony. So when you're trying to make a diagnosis in a patient or trying to discover the cause of a symptom in a patient, and there are multiple different causes, you try and put everything in together, all the symptoms, all the signs, all the tests, and come up with one diagnosis that would explain everything. That's Occam's razor. It doesn't work very well in our situation when we're trying to figure out why a patient with scleroderma might be breathless. So instead of Occam's razor, I instead look at Hickham's dictum, which is a patient can have as many diseases as he damn well pleases. Or there are many multiple different causes, in this case, for being short of breath if you have scleroderma. So in addition to all of these causes, you have to keep in mind, Hickham's dictum says it can be multiple different ones, combinations of these, and so it's very, sometimes takes a lot of different expertise to sort this all out. So these are the major causes, and now I'm going to we're going to now transition from this introduction into the mechanics and the physiology of breathing. So in terms of the mechanics of breathing, The lungs, of course, are in the thorax, and the thorax has to expand in order to get air into the lungs. So this expansion of the thorax, it works like a bellows. So the diaphragm, the muscle that separates the thorax from the abdomen, contracts, the muscles around your rib cage contract, and your chest expands, and that creates a negative pressure which allows air to flow into your lungs. And so in some situations, we see patients who are weak from muscle inflammation, polymyositis occurring in association with scleroderma. And their muscle weakness may actually impair their ability to get enough air into their lungs, and that can lead to shortness of breath. Or as shown on the right side of your screen, it doesn't show up very well because of the lighting in here, but sometimes we'll find patients where the skin over the chest wall is so tight it restricts the expansion of the chest. And we'd have to do certain breathing tests and certain imaging studies to figure this out, but that is one potential cause of shortness of breath. Another factor is reflux, which is so prevalent among our patients with scleroderma. And the slide on your left, the diagram, shows you the very close relationship between the esophagus and your airways. And so we know that in our scleroderma patients, the lower esophageal sphincter doesn't function normally. The esophagus, the peristalsis in the esophagus is reduced. And so contents of the stomach can reflux back, and actually reflux back into your airway, your upper airways, and perhaps even into the lower airways. So it's not terribly uncommon for some patients to have shortness of breath that is related to gastroesophageal reflux. They may also have hoarseness, other symptoms that would suggest that GERD is playing a role. Now, once you breathe the air in, it goes into the lower respiratory tract, and it goes to the alveoli, which is the smallest. So the airways continue to branch. They get smaller and smaller as they move out towards the periphery of the lung, and they end up in a small sac that's called an alveolus. Alveoli is a Latin term for cluster of small grapes, and you can see from this cartoon in the circle there that each alveolus, as they're clustered together, and they resemble a bunch of grapes. And that's really where the action occurs. That's where oxygenation occurs, in those alveoli. That's another diagram there. Let's see. Yep. So, if normal respiration depends on a very high surface volume. We're talking about the surface volume of air and blood. So oxygen has to go from the air into the blood, and carbon dioxide has to go in the opposite direction. And in order to efficiently breathe, you have to have a huge surface area. So the surface area, if you could take those alveoli and move them from 3-dimensional to 2 dimensions and spread them out so they're one alveolus thin, it would take up the area of a tennis court. So there are lots of alveoli. How many alveoli in a single human lung? Anybody want to take a guess? A billion, not quite. Huge. Actually, it's 300 to 480 million alveoli. And if you stretch them out in 2 dimensions, it would cover a tennis court. And so that's why we have so much reserve. You know, people can have a pneumonectomy, they can lose a lung, and they can still function fairly normally. So there's a huge amount of reserve built into our lungs. So this is an old anatomist drawing of the alveoli, and the red are the arteries and the blue are the veins. And you can see the intimate relationship between the circulation, the blood, and the air. And on this slide, this is actually from a frog lung, but they're similar to ours in this respect. So those are alveoli, individual alveoli. You have the air space and a very thin membrane, and the capillaries are around the air spaces, and within the capillaries are the red blood cells. And this is an even higher power. This is an electron microscope power that shows you a red blood cell. That dumbbell-shaped object is a red blood cell, and you can see how close it is to the air. And that's how we depend on, that's how we can breathe so efficiently, because there's a very thin membrane that allows oxygen to come in and carbon dioxide to go out. And if you look at a normal lung, histologically on your left, you see those normal alveoli. And on the right is a section of lung from a patient with scleroderma. That's interstitial lung disease. And you see that whole anatomy, the microanatomy is different. You don't have as many alveoli, and you have a lot of space due to inflammation, cells, and collagen fibrosis, which is increasing that space between the air and the blood. And that can certainly impair respiration. So this is a very important part, and this is why interstitial lung disease leads to shortness of breath. Now, we talk about the air coming down into these alveoli. The other important component is the blood. So blood has to get to the lungs to deliver the red blood cells to pick up the oxygen and release the carbon dioxide. And so this then depends on cardiac function. And here we've taken the heart and sort of split it into two parts, the right side and the left side. So RA is right atrium, RV is right ventricle, and the right ventricle pumps blood, deoxygenated venous blood that comes back to the heart. The right ventricle pumps it then to the lungs. And this is designed to be a very low pressure system. You can imagine if you have, let's say, 400 million alveoli in each lung, and you have those capillaries are very thin. This is a low pressure system. So the right ventricle is not designed for high pressure. And so it pumps under low pressure, it pumps the blood to the lungs. There in the alveoli, individual alveoli, oxygenation occurs. And then that oxygenated blood returns to the left atrium, then the left ventricle, and then it's pumped out to the brain and the other vital organs. That's a high pressure system. So because of gravity, we're standing, you have to pump blood to the brain and extremities. So the left ventricle is designed for a high pressure system, but the right side of the heart is not. Well, what can happen in scleroderma? So if you look at a normal pulmonary artery or arteriole, small pulmonary vessel, you see on your left, it has a very thin wall. So the right ventricle is pumping blood through these very thin-walled blood vessels, and it can do that because there's not a lot of resistance. And it's designed to pump blood under low pressure. Oops. In scleroderma, as shown on your right, this is a patient who has pulmonary arterial hypertension. All of a sudden, that blood vessel is very narrow. And you can imagine trying to pump blood through that. So if you're in your garden and you're watering your flowers or your vegetables, and there's a kink in the hose, in order to get the same amount of water to your garden, the pump has to pump harder. And the pump in this case is the right ventricle. It's not designed to do that. So it will get bigger like any muscle, but after a point, it starts to fail. So you get what we call right-sided heart failure due to pulmonary hypertension. And this, because not enough blood is getting to the lungs, this leads to shortness of breath. I mentioned this earlier. The key component here is hemoglobin. That's the molecule inside the red blood cells that carries oxygen. So if you don't have enough hemoglobin, you have anemia, you can become short of breath. So, for example, somebody might have esophagitis and they may have low-grade bleeding, intermittent bleeding, or they might have what we call watermelon stomach, where the blood vessels in the stomach and elsewhere throughout the intestinal tract kind of ooze blood, and it happens so slowly you don't notice it until you become anemic and you can't carry enough oxygen in your hemoglobin and you become short of breath, or your shortness of breath worsens. So anemia is another cause for shortness of breath. So we have all of these potential confounders or causes of shortness of breath in our patients. How do we figure it out? How do we sort it out? And this really requires not just a rheumatologist and internist, but it may require a radiologist, a gastroenterologist, pulmonologist, a cardiologist, a real team of people. And this is why I think most of our patients deserve to be seen at scleroderma centers, where the pulmonologist has seen a lot of scleroderma patients, or the radiologist has read a lot of images from scleroderma patients, and everybody is communicating with one another. So we start with the history and the physical exam. We do certain blood tests, and I'm sure most of you have had many of these studies, not all of them, but we do pulmonary function tests, or PFTs. We can do various X-ray and other imaging studies, echocardiogram, sometimes bronchoscopy, lung biopsy, rarely, and cardiac catheterization. So there, again, not everyone is going to need every one of these studies, but these are the tools that we use to sort of sort out why you might be short of breath, because again, the point I'm hitting repeatedly is that there can be multiple different causes for your symptoms. So the history is key. Always start by inquiring about the patient's ability to exercise or to do activities of daily living. This can sometimes fool the physician if they're not careful, because patients may adapt to their situation. They may do the same amount of work, but they may take 2 days instead of 1 day, or several hours instead of 15 minutes. So patients are very adaptive. But we have to sort of tease that out and find out if they are short of breath, if they might be having a reduction in their normal exercise capacity. Cough is a big symptom. If the cough is productive of sputum, we worry about infection. If there's blood in the sputum, we worry about things like a blood clot. Usually it's if it's interstitial lung disease, it's a dry cough, non-productive, but it's an important symptom. Chest pain isn't a very common symptom, but it can sometimes happen if there's inflammation around the lining of the lungs, pleurisy, or inflammation around the lining of the heart, pericarditis. Or it could be totally unrelated to the scleroderma. You might have coronary artery disease and angina, and that may need to be investigated with certain tests. Important to take a thorough history about smoking and about occupation. So some people, through their occupation or even their avocation, have been exposed to chemicals or other substances that may cause or exacerbate interstitial lung disease. So the history is important, and the physical exam is important as well. So on the physical exam, we listen with our stethoscopes, and we might hear, the lung fields may be completely clear, which points away from interstitial lung disease or suggests that the pulmonary fibrosis isn't very severe. If we hear what the doctor might describe as crackles or rowels, that's a suggestion that there could be pulmonary fibrosis or sometimes even some heart failure. So the physical exam is still important. We do a host of studies. Again, not everybody's going to need all of these studies, but everybody should have a blood count Why do we want to know what the blood count is? Exactly. So we want to make sure the patient isn't anemic, which could be contributing to their shortness of breath. We test for certain muscle enzymes. If the muscle enzymes are very elevated, then weakness may be playing a role in their shortness of breath. There's a hormone called BNP, which is released from the heart when the heart is stretched or dilated, when it's a sign of heart failure. So that test may be done. And then everybody with scleroderma usually has tests. They have an ANA and sometimes tests for other autoantibodies. And some of those autoantibodies have been found to be associated with certain pulmonary conditions. So for example, SCL70 and some of the RNP antibodies tend to be associated with pulmonary fibrosis. Whereas other ones like centromere and one called THTO can be associated with pulmonary arterial hypertension. They're not diagnostic, but they put patients in a certain risk category, and so it indicates to the rheumatologist you may look at certain things more frequently or carefully than otherwise. Now, how many people have had pulmonary function tests? So everybody. So these are very useful to us. They should be performed at the baseline visit, whether you're short of breath or not, so that we have a good baseline and we know what your pulmonary function is. This is a non-invasive test, so it can be repeated at various intervals. We'll come back to how often that should be done. And as you know, when you do the pulmonary function tests, it's very dependent on your participation and also on the skills of the technician. So a lot of our patients have difficulty with opening their mouth wide. So the technician has to work with you and use a small mouthpiece if that's an issue, or a pediatric mouthpiece, or an adapter. Because we put a lot of emphasis on the pulmonary function test. It has implications for the medications that might be prescribed. So if they're not done properly, you're not going to get very useful results. So and there's a battery of tests that are done, depending on what your doctor orders, but one that we look at is called the forced vital capacity, and that's how much air you can breathe out, which is actually a reflection of how much air you can breathe in, of course. So the forced vital capacity is very important, and when it starts to fall, we worry about interstitial lung disease or pulmonary fibrosis, or it could be restriction from the chest wall or from muscle weakness. There's another test called the diffusion capacity, or the DLCO, which measures how well oxygen is coming in and carbon dioxide, but in this particular test, they use carbon monoxide. And that really tells us a lot about that blood-air barrier, that blood-air interface that's so critical to normal respiration. So a fall in the DLCO could be due to the fact that you're not getting enough air in because you have pulmonary fibrosis or restriction, or it could be if the forced vital capacity is normal and the diffusion is going down, that could be a harbinger of pulmonary hypertension. Or it could be from emphysema if you were a smoker. So these, again, we get a lot of clues from the pulmonary function test. It usually allows us to tell the patient that she has or does not have restrictive lung disease, pulmonary fibrosis, or perhaps pulmonary hypertension, which is going to require additional testing. So PFTs are critical. One of the pulmonary function tests is a 6-minute walk test. And I know many of you have had the 6-minute walk test. And this is, again, very dependent on how you feel, what kind of shoes you happen to be wearing that day, whether your muscles and joints are bothering you. And it's also dependent on the skills of the technician who's doing the test and where they put the oximeter. This is not a headband, that's not a sweatband, that's a oximeter on the forehead. But most PFT labs that are not familiar with scleroderma patients or people with Raynaud's phenomenon have a finger oximeter or an ear oximeter, and they don't work very well for us. So again, it illustrates the importance of going to a center that is familiar with your disease. The distance that you walk in 6 minutes is probably the most important test we can do. It's just one of the pieces of the puzzle, but it's a very important piece. And we can follow that. We can see the distance that you walk in 6 minutes at this point in time. We can do it again in 6 months or a year, and we can look for trends. And with some of the drugs that have been developed for pulmonary hypertension, this is one of the tools that has been used to see if those drugs actually work. So people would have their 6-minute walk test before the drug study started, and while they were on the drug, and the difference in those two measurements would be compared. This test also tells the physician if the patient is going to need supplemental oxygen. If the oxygenation falls while you're walking below, let's say 88%, below 89%, you qualify for supplemental oxygen and probably should use it. This again is a very useful test. The chest x-ray, everybody's had a chest x-ray. This doesn't give us as much information as we need. We do the chest x-ray, particularly if a patient has an acute exacerbation. They come in, all of a sudden they develop acute shortness of breath, or a cough that's gone from a dry cough to a productive cough. And we're worried about sometimes a collapsed lung, sometimes a blood clot to the lung, or a pneumonia. But the chest x-ray really has, for most of our patients, has been replaced by a more sensitive test, and that's the HRCT, high-resolution CAT scan of the chest. So this is much more sensitive than a chest x-ray. So think of a chest x-ray as a loaf of bread, looking at a loaf of bread. A CAT scan is looking at each slice of that loaf of bread. So it gives you a lot of detail. And we can see very subtle changes or more advanced changes depending on the severity of your interstitial lung disease. And so the CAT scan is very important in defining the presence and the severity of pulmonary fibrosis. It has significant amounts of radiation, so it's not something you want to have done very often, but nevertheless can be important as a baseline test in the workup of shortness of breath. Bronchoscopy we have gotten away from in recent years. We now will mainly do bronchoscopy if we're worried about infection. For example, if you're on an immunosuppressive drug like Cytoxan or Cellcept, and you have fever and cough, and we may need to find out if you have some sort of infection. And so the bronchoscopy would be one way of doing that. We also still do it for research purposes. And we're able to obtain cells from the lower part, from those alveoli. And we can look at them. The cells on your far right, those are inflammatory cells. They shouldn't be in your lower respiratory tract. They indicate that there's an inflammatory process occurring in the lower part of your lungs. We can actually grow fibroblasts from the fluid that we recover through the bronchoscope. So this has been very helpful for us from a research perspective. Lung biopsies, fortunately, do not have to be done very often in scleroderma patients. Unlike our pulmonary colleagues that are seeing people who don't have a known cause for their pulmonary fibrosis, there a biopsy is usually indicated. In our patient population, we know that people are at risk for interstitial lung disease. So if we see it on the CAT scan and on the breathing test, we don't usually need to do a bronchoscopy to define it. How many people have had an echocardiogram? So this is looking at the blood flow to the lungs and looking at the function of the heart. And of course, this is completely non-invasive. Sound waves are used to look at the anatomy of the heart. And we can get some idea if the right side of the heart is under stress, under pressure overload. from a number of different parameters that they can measure during this procedure. We can get some idea of the left side of the heart, the left ventricle, to see if it might be abnormal or dilated or hypertrophied. Sometimes we'll see pericardial fluid around the heart, an increase in fluid around the heart that can contribute to chest pain or sometimes shortness of breath. And sometimes we'll pick up things unrelated to your scleroderma, a valve problem with the mitral valve or the aortic valve. So it's a very useful test because it's non-invasive and gives us a lot of information. You cannot diagnose pulmonary arterial hypertension by an echocardiogram. You can have a clue that it might be present, but what do you really need to diagnose pulmonary arterial hypertension? See, you guys could give this lecture. Right heart catheterization, which is a lot less involved than a left heart catheterization. Sometimes you need both, and they're done at the same time. But the right heart cath is done to actually directly measure the pressures in the pulmonary artery, and at the same time make sure that the left side of your heart isn't failing. So this is a critical procedure. It's invasive, but safe, and gives us a lot of information. And I certainly would never put a patient or try and put a patient on a drug that might cost $75,000 to $100,000 a year without knowing that they truly have pulmonary arterial hypertension. So the echo can be wrong, and really the right heart cath is required to know if you have pulmonary arterial hypertension. So we've gone to first and second year medical school. That was the mechanics and the physiology of breathing. We've done third and fourth year medical school, which is the testing, the history, physical exam, and all the testing. Now we can turn to treatment. And treatment is really going to depend on what we found with all those studies. Hopefully you don't have any dyspnea and you don't have any need for any specific treatment. But if you do have dyspnea, shortness of breath, hopefully your doctor has figured out the cause. If it's anemia, you're going to get a blood transfusion and they're going to look down to make sure you're not bleeding. If it's interstitial lung disease, you'll get a different treatment. If it's pulmonary hypertension, you'll get another treatment. So the treatment is really going to depend on the cause. But there are some things that apply to everybody, regardless of what the cause might be. So you want to avoid cigarette smoke. You want to do your very best to minimize GERD, reflux. You want to make sure that your usual immunizations are up to date. You get your flu shot every year. You get your pneumococcal vaccination regularly. You want to exercise because the more efficient your muscles are at using the oxygen that they get, the less work your heart has to do to get blood there. So sometimes you'll need a prescription from your pulmonologist or your rheumatologist for pulmonary rehab, where it's more supervised. But exercise, whether it's a recumbent bike or walking or swimming, is very important. Cough is a major issue, and I've heard a number of people coughing throughout this talk, and it can be a very distressing symptom for patients and very difficult to treat. And sometimes it will require opioid medications to help control the cough. And then supplemental oxygen if you are found to have a low oxygen level, or if during exercise it drops below, let's say, 89%. So those apply to all patients regardless of what might be causing their lung disease. So let's look at the two major issues. One is pulmonary fibrosis, and then we'll look at pulmonary hypertension. So not everybody is going to need to be treated for pulmonary fibrosis. Some people have only a very mild degree of it on their CAT scan. We can't hear it. Their PFTs are pretty normal, and they're not going to require treatment. So we want to find out, is the patient short of breath? Is there evidence of pulmonary fibrosis by PFTs, by CAT scan, and how severe is it? And what's really important to me as a clinician is it getting worse? All of a sudden, have you slowed down in your work capacity? Is your forced vital capacity going down when we look at your PFTs today compared to 6 months earlier? Are we looking at seeing trends that suggest that your pulmonary fibrosis is getting worse? And the CAT scan can be repeated once in a while to see, in fact, if it is getting worse. And if it is, then that patient probably needs to be treated. So this doesn't show up very well because of the colors and the light here, but this is an algorithm that has been suggested that we use. So at baseline, if in a patient with shortness of breath, we get tests including PFTs and a CAT scan. And if those are normal, fine, we say come back and we'll do your breathing test in a year. If those are abnormal, we look on the CAT scan to see how bad it is, how much of the lung is affected. If there's a lot of lung involvement, we would then say that person merits treatment. If it's limited in the amount, then we look at their PFTs more closely. We don't say come back in a year, we say come back in 3 or 4 months. And we see if those PFTs are staying stable, eventually we'll move them to once a year. If the PFTs are getting worse, then that patient merits treatment. So again, that's the way we use several of these tools and individualize them to every individual patient, because many people will not need treatment for pulmonary fibrosis. So the first really big study was the Scleroderma lung study, and some of you may have participated in that study. And this was a placebo-controlled study, so half the patients got a placebo and half the patients got a drug called cyclophosphamide. And they were treated for a year and followed for another year. And this slide sort of shows the results, and I'm not going to dwell on it, but it doesn't show up very well. But the bottom line was that at 12 months and even 18 months, the people who were getting cyclophosphamide had some improvement, slight improvement in their lung function. And their skin score, tightness of their skin improved. And their degree of dyspnea improved as well. But by 24 months, being off the drug for a year, they were back to where they had started from, and no different than the group who got placebo. So that then led to the design of Scleroderma lung study 2. In this case, there was no placebo group. Patients either got cyclophosphamide for 1 year or they got CellCept for 2 years. So the idea was to compare 2 years of CellCept to 1 year of cyclophosphamide to see which would be more effective and which would be better tolerated. And this study was just completed, or has been completed, was published this week. So this is right off the press. It was published in Lancet Respiration. And the slide on your left shows the forced vital capacity. So the pulmonary function test that we looked at. And both lines are going up. One line is for cyclophosphamide, one line is for CellCept. And you can see that they both went up slightly, and there was no difference between the two. The slide on your right is a skin score. In this case, going down is better. And so you see that both groups of patients had softening of their skin at 2 years. And there was no difference between the two groups, cyclophosphamide for 1 year, CellCept for 2 years. The other important part of this study is shown on this slide, and the top line is the percentage of patients who took CellCept and were able to stay on it. And the bottom line, the solid line, is a percentage of patients who took cyclophosphamide and were able to stay on it. So basically what this shows is that the first two slides show that cyclophosphamide and CellCept are comparable in terms of effectiveness, but that this slide shows that CellCept is better tolerated and people are able to stay on it longer. And Colleagues at UCLA and around the country are in the process of designing SLS3. We don't want to go out of business until we find a cure for this disease. So SLS3 is being designed, and you need to stay tuned for that. But there are a host of other drugs being used to treat this complication of scleroderma, interstitial lung disease, or pulmonary fibrosis. If you go to a website called clinicaltrials.gov and put in scleroderma lung, you'll find all the trials around the country and actually internationally that are being studied. And just a word about stem cell transplantation, because I know this is of great interest and importance to our patients. So one of the most recent study that was published also in the Lancet and I think later in JAMA shows a marked improvement in lung function in patients who got stem cell transplant, even patients who had failed cyclophosphamide. The studies I'm showing you on this slide are from larger studies, international studies with a much longer follow-up. And each of those lines represents one patient, and the solid line is sort of the average of all of those patients. And on your left is the forced vital capacity, on your right is the diffusion capacity, and you can see that they're basically flat or maybe slight improvement in the FVC and a slight decline in the diffusion capacity. So stability, and we're looking forward to the results of the stem cell study, the Scott study that was done here in the States. And one of the key outcome measurements will be lung function. So again, we have to stay tuned. Some patients fail to respond to anything and might be considered a candidate for a lung transplant. And there are only a few centers in this country that will do lung transplants in our patients with scleroderma. And the big hindrance there is reflux and the esophageal dysfunction or dysmotility that leads to reflux, which can cause rejection of the transplanted lung. So there are many transplant centers that won't even consider a scleroderma patient. When you look at the data, though, for the centers that do lung transplants for scleroderma patients, the outcome is pretty good. In fact, it's no different than other diseases, at least the 5-year outcome. So we're hopeful that as more transplant centers see these data, that they may be able to consider more of our patients who might need a lung transplant. So that's interstitial lung disease. That's where we stand now. Pulmonary arterial hypertension, sort of another side of the coin. And again, you can have both, but most of the studies have been in people who have one or the other. So this slide is a cartoon from a review article many years ago now in the New England Journal of Medicine. It just shows different pathways that lead to pulmonary arterial hypertension, either idiopathic PAH or scleroderma-associated PAH. And for our purposes today, the importance of knowing these pathways that have been worked out by basic scientists over the years is that the translational scientists and pharmacologists have developed drugs that are focused at each of these different pathways. And so now we have, I think, 13 different drugs for pulmonary arterial hypertension. So I've been doing this about 35 years. I served on the Data Safety Monitoring Board for the first FDA-approved drug for pulmonary arterial hypertension, epoprostenol, Flolan. And in the 20 years or so since that, there's just been an explosion of different drugs attacking each of these different pathways. So now people are developing algorithms to decide when to use these drugs and how to use them. So we have drugs that will block endothelin receptors. We have drugs like the erectile dysfunction drugs that increase nitric oxide. We have other drugs that increase nitric oxide, which causes those blood vessels to dilate so you can get more blood to those alveoli. And so I think now probably the trend is for people to, most people are going to require more than one drug for this disease. And so two or sometimes three of those pathways will be attacked. So some people may start out on one drug and then have another drug added. There's some data coming out that suggests that maybe people should be started at the beginning on two different drugs. And then there are different ways of giving the drugs. You can take them as pills, you can inhale them, you can take them subcutaneously as an injection or intravenously. So I'm very encouraged by the development of new drugs, both for pulmonary fibrosis and now for pulmonary arterial hypertension. And there is, I think, very good evidence that these drugs are making a difference. When we look at the survival of scleroderma patients who have pulmonary arterial hypertension and are being treated with the drugs that we have now, and we compare them to patients who were at the, I don't know what I just did, who were being treated at the best centers in the world before we had any of these drugs, we see an improvement in survival. So I'm going to close now. I'd like to thank the funding agencies that have supported my work, including the Scleroderma Foundation, all of my colleagues at the Scleroderma Center at the Medical University of South Carolina, of course, my patients and all of you who participate in the important clinical research that we're doing, and the volunteers who work with the South Carolina chapter, as well as all the chapters represented here today, and be happy to answer any questions if I may. So the question was, what proportion of scleroderma patients have both interstitial lung disease and pulmonary hypertension? And it's a little hard to answer that question because we don't have a lot of good data, but also if you have very severe interstitial lung disease and your oxygen levels are low, you can get pulmonary arterial hypertension from that. So, as well as from having the actual disease begin in the blood vessels in the lung. But I'm going to guess it's no more than 10% have both. It's tricky, too, when it comes to treatment, because the drugs we use to treat pulmonary arterial hypertension work by dilating those blood vessels. And if we give a patient those vasodilators and we open up the blood flow to parts of the lung where the air isn't getting in because of the fibrosis, we can actually make them worse. Their oxygen levels can go down. The blood is going to areas that's not getting air. So we have to be very careful in treating those patients. Yes? So this question I get all the time. It relates to cough and how to treat it. The way I approach that is first I try and make sure the patient isn't having too much GERD and try and do everything I can to manage their GERD because that can play a role. But you can have cough related to the fibrosis in the lung, not related to GERD. So if it's not getting better when you're treating the GERD and you think it's from the lung, we don't have great medications for that. I'll usually try something called Tessalon pearls, which helps some patients. But what I've found is that in patients who have severe pulmonary fibrosis and this chronic cough, the opioid medications are probably the most effective. And again, that's like walking a tightrope, because you don't want to depress your respiration with an opioid medication. But if you can use low doses that often, and sometimes there's some anxiety associated with the cough, and if you can treat both the cough suppress the cough with an opioid and treat the anxiety with an anxiolytic medication, that can help improve symptoms for some patients. Way back there. So her question relates to her pulmonary function test. The FVC is normal, and the DLCO tends to fluctuate. So the DLCO measurement is much more sensitive to error, prone to error, than the FVC. So if your effort is different, if the technician is not as good, it's also has to be corrected for your hemoglobin, and a lot of times they don't know what your hemoglobin is at the time of the breathing test. All of those can factor into it. And that's why I'm glad you asked that question, because it reminds me to tell you that we look for trends. And if your DLCO is sort of bouncing around up and down, that's not a bad thing. There's some noise in the system. But if it's going down and continues to go down, that worries me, and then I'm going to look into that. And we know from work that Dr. Steen did a number of years ago when she was at Pittsburgh, that when the forced vital capacity is normal, the DLCO starts to go down. That's a warning sign that that patient may be at risk for developing pulmonary hypertension. So again, I would want, in that patient, I'd want to see what the trend was. I want to look carefully at the echocardiogram. And in some cases, depending on what the echocardiogram showed, I would want a right heart catheterization. But the DLCO is very sensitive and can fluctuate more than the FVC or the total lung capacity. So again, you want to look at trends. And again, comparing PFTs at one lab to your doctor's office, say to the lab at the hospital, is fraught with error. So I like to have my patients get their PFTs at the lab at my hospital, which I know is certified by the American Thoracic Society. I know that I'm getting good information, and usually it's consistent. Yes. So that's a very important question. It relates to patients requiring medication for pulmonary arterial hypertension and the fact that many people are going to require more than one. These drugs are very expensive. That's why it's so important first to make sure you do have PAH, pulmonary arterial hypertension, and that's why you need the right heart cath. One day, cardiac MRI may replace that invasive test, but now it's the cardiac cath. If, for example, on the cath, we find that the pulmonary pressure is high, but something called the wedge pressure is also high, that's not pulmonary arterial hypertension. That's problems with the left ventricle. And that patient needs a drug like lisinopril, or what we call an afterload reducer, which is not expensive. So first thing is to make sure you've got it. Then, if you are on treatment and you require drug therapy, you have to get prior authorization. If it's 2 drugs, or in some cases it's 3 drugs, it's more prior authorization required. This is why you need to be seen at a pulmonary hypertension center, where they have the manpower, woman power, to do this, work with the insurance companies and work with the drug companies themselves to make it available to people. My impression is that most of the pharmaceutical companies have been very good about making these drugs available. But it requires work on the part of the patient and on the part of the provider, whether it's the pulmonologist, the rheumatologist, or the PA who works in the pulmonary hypertension center. But it's very important to work with a team of doctors who know how to do this, how to navigate the system. I think we have time for one more, right here in the middle. Yeah, great question. And I'm biased because I'm at an academic health center, and my clinic is literally 15 yards from the PFT lab. So my pulmonary colleagues are right next door to my clinic, and we have a PFT lab that knows how to do these tests. So you can go to an academic health center. Sometimes your insurance companies won't let you do that. I see patients who are referred to me and I want to get PFTs, and their insurance company says, no, you've already had them in Louisville or Knoxville or Atlanta, you can't get them. I still try and get them, but not always. But you can make sure that the PFT lab is certified by the American Thoracic Society. And I think that's the best you can do. Thank you all very much. Enjoy the rest of the day.